Good afternoon, everybody. A very age-old and very valid teaching, which is even important at this age. Whenever we see a case, we should try to explain all the phenotypic features with one cause. But we need to keep in mind that there may be exceptions to this particular teaching. And today from Pediatrics Unit 2, we will be discussing two interesting cases with a dual phenotype, which we were able to demystify using next generation sequencing techniques. Dr. Soumanya, who's a senior resident in DM Medical Genetics, would be presenting and discussing these cases. Thank you.
Thank you, ma'am. As ma'am told, we'll be going through two cases with complex phenotypes, which we were able to solve thanks to the power of next generation sequencing. So we'll start with our first case. This is Miss A. She's a 10-year-old girl, had presented with complaints of reduced vision in the night, noticed since 3 years of age, and history of bleeding manifestations, which was noticed since 5 years of age. There was no history of hearing impairment, abnormal movements, or jaundice. She had a history of seizure at 1.5 months of age, although the cause was not known. And there was history of recurrent blood transfusion, once requiring red bloods and twice platelets were transfused. Also, for her thrombocytopenia, she was on and off steroids. There was no history of surgery and her development was normal. On examination, she had pallor and bilateral retinitis pigmentosa. She had a massive splenomegaly, the spleen being around 15 centimeter below left costal margin and was firm in consistency. Rest of the systemic examination was essentially normal. In family history, there was no significant family history. So her investigations showed anemia and thrombocytopenia, and she also had leukopenia. For these complaints, she was treated in multiple hospitals, initially as ITP, then she was treated as for brucellosis, and also received steroids on and off, IVIG, rifampicin, azathioprine, and hydroxychloroquine for suspicion of autoimmune disease. So for her splenomegaly, she did not have any history of fever. Her blood, she had bicytopenia and pancytopenia, no markers of hemolysis. Her bone marrow examination was normal, and in view of organomegaly with pancytopenia, enzyme assay for storage disorders, that is Gaucher disease and Niemann-Pick was done, which was also normal. And her ultrasound abdomen showed splenomegaly, and her LFTs were normal. So basically, we have a child who is developmentally normal and had splenomegaly with pancytopenia and retinitis pigmentosa. So in view of these two distinct phenotypes, that is a phenotype of probable storage disorder or some kind of hemolytic disorder with retinitis pigmentosa, we went ahead and did whole exome sequencing in the child. So the whole exome sequencing showed a homozygous pathogenic variant in the PDE6B gene. So this PDE6B causes retinitis pigmentosa type 40, and this was likely pathogenic according to ACMG classification. She had a heterozygous variant in SMPD1 that causes Niemann-Pick disease. However, her enzyme assay was normal, so this variant was ruled out. Interestingly, she had a copy number variation, that is a micro deletion that was there in chromosome 22, and it was there in the 22q11.2 region that causes DiGeorge syndrome, and this was a pathogenic variant. So coming on to the individual phenotypes, so retinitis pigmentosa 40. This is the PDE6B gene, that the variants that have been reported till now that cause retinitis pigmentosa. So our variant lies in this domain of the protein, and this is the autosomal recessive disorder, and there is progressive retinitis pigmentosa with intraretinal bone spicules, attenuated retinal vessels, and absent night vision, which was matching with our patient's phenotype. Since she had a copy number variation in the 22q11.2 deletion region, so we reverse phenotype the child. So on reverse phenotyping, we saw that she had this hooded upper eyelids and a tubular nose, a prominent nasal bridge, mildly hypoplastic ala nasi, overfolded helices, and slight retrognathia. Also, on digging deeper, we came to know that the seizure that had occurred in her infancy was actually a hypocalcemic seizure. And on further investigation, she was found to have reduced B cells, hypocalcemia, and hypoparathyroidism. So her phenotype was actually matching with 22q11.2 deletion. 22q11.2 deletion is a microdeletion syndrome. It's one of the most common microdeletion syndromes. So these are the common breakpoints at which this microdeletion occurs. The most common being a 3 MB deletion, that between LCR-A and LCR-D. So our patient also had deletion in this common 3 MB deletion. Otherwise, the other deletions which are known are of 1.5 MB and 2 MB. Also, some atypical cases of distal deletion are known in 22q11.2. So when we phenotype, the phenotype that is described in 22q11 is of immunodeficiency, congenital heart diseases, which can occur in up to 75% of the patients, craniofacial dysmorphism, and hypocalcemia, hypoparathyroidism. Most of the patients have mild to severe developmental delay. They can also have some ophthalmological features and skeletal abnormalities, and interestingly, they can also have some autoimmune disorders. So our patient had these craniofacial manifestations, endocrinological features, and the autoimmune disease. So these are the various craniofacial features which are found in 22q11.2 deletion. So these include cleft palate hypertelorism, ear anomalies, short down slanting palpebral fissures, short philtrum, and a bulbous nose. However, still the cause of splenomegaly with bicytopenia was not clear in this child. So, there were 3 possibilities. Either it could be a severe infection due to immunodeficiency, which was ruled out in this child, and there was no malignancy. We couldn't find any evidence of any malignancy. So the third possibility was of immune dysregulation. So we did some more literature search, and we found that it has been reported that in patients with hypoplasia of the thymus, there can be impaired central tolerance, which can lead to escape of the autoreactive T cells, T lymphocytes, which can lead to immune dysregulation and autoimmunity. And probably this was the mechanism of the manifestations in our child. So there have been some isolated case reports which have reported these autoimmune manifestations. So this was in this report they had reported that there is a higher prevalence of double negative T cells in the 22q11.2 microdeletion patients. However, there is no significant association of autoimmune lymphoproliferative syndrome with this elevated DNT cell count. This was a report from China, in which they had followed a 15-year-old Chinese girl who had the typical features of 22q11.2 deletion. She had a distal deletion, and she also had this splenomegaly with autoimmune thrombocytopenia and anemia, and she was treated with glucocorticoids and calcium supplements, and they noticed a response. So her thrombocytopenia had increased from around 7,000 to the range of 60 to 90,000 after glucocorticoid treatment. And this was another case report in which they had reported a patient of 22q11.2 deletion with probable AIIMS. So in this also the patient had had pancytopenia with splenomegaly, and this patient was treated with sirolimus. and a marked response was seen, and they have hypothesized this that probably inhibition of the mTOR pathway can help in treating the autoimmune manifestations in these patients. So the final diagnosis in this patient was retinitis pigmentosa type 40 with 22q11.2 microdeletion syndrome and splenomegaly bicytopenia, probably secondary to immune dysregulation. So now we go on to our second case. In this child we have planned a trial of steroids, and her long-term follow-up for evolution of the phenotype is to be done. Her echo is normal, and genetic counseling and parental screening is important because in case one of the parents is carrying the microdeletion, there can be a 50% chance of recurrence in the subsequent pregnancies. So now we come to our second case. So this was a child who was antenatally diagnosed to have situs inversus totalis. She had a history of NICU stay for 1 week in view of respiratory distress. And since 1 to 1.5 months of age, she continued to have recurrent episodes of cough and rhinitis every 15 to 20 days and 2 to 3 episodes of pneumonia. So for this, she was under Peds pulmo follow-up, and she was suspected to have primary ciliary dyskinesia. Again, at 4 to 4.5 years age, she was found to have speech delay, for which she was evaluated and was found to have autism according to DSM-5 criteria. So in view of this a monogenic disorder, that is probable primary ciliary dyskinesia, and to find the cause of autism in this child, she was referred to our genetics clinic. On examination, her anthropometry was appropriate for age. She did not have any significant dysmorphism apart from hypertelorism, and otherwise she had dextrocardia, and rest of the systemic examination was normal, and family history was also non-contributory. Her X-ray chest showed dextrocardia with peribronchial thickening, likely early bronchiectatic changes, and the fundal shadow was on the right side. EEG was done, which showed bilateral parieto-occipital epilepsy, and ultrasound abdomen showed situs inversus. And her high-speed video microscopy was done in the Peds pulmo, and this is a representative image. So in this we can see there is absolutely no movement of the cilia versus the normal ciliary movements in a normal patient. So by this she was diagnosed to have primary ciliary dyskinesia. So in database we have a child with 2 apparent different disorders, that is a suspected primary ciliary dyskinesia and autism. So although the first line of management in cases of autism is testing for Fragile X syndrome and doing a CMA, however, since the child had a suspected monogenic disorder as well, so we went ahead with whole exome sequencing. So the whole exome sequencing showed a variant in CPAP 300. So this is one of the rare causes of PCD, and in this the report showed a homozygous missense variation in the CFAP 300 gene that is a reported variant and is a likely pathogenic variant. There was also a VOUS in the SETD5 gene that causes intellectual developmental disorder. However, the clinical features of this was not matching with the patient phenotype, so we disregarded this variant. And now the twist came. So she had a deletion, a micro deletion in chromosome 11. So this was a 6.06 MB micro deletion, and as we'll see in the subsequent slides, this micro deletion has the CPAP 300 gene. So basically, on one of her alleles there was a missense variant, and on the other allele there was a deletion. So this resulted in a precipitation of an autosomal recessive condition in the child. So we did segregation in the parents, and we found that mother was a carrier of this missense variant, and father had the wild type variant. So, primary ciliary dyskinesia type 38 is caused by CPAP, by variants in CPAP 300 gene. So, this basically this CPAP 300 is involved in transport of the DNA H5 and DNA H9 protein to the outer ciliary axoneme, and in absence of that protein, these proteins are not transported to the axoneme, and this hampers the interflagellary transport. So interestingly, the first time this gene was discovered was with a variant that our patient also had. So this variant is conserved across all the species, this amino acid histidine, and in this electron microscopy also it can be seen that the inner and the outer diamine arms are not present in the diseased patient's cilia. So these were the three initial cases which were found to have this variant, and they all of them had features of neonatal respiratory distress with wet cough, rhinitis, dextrocardia, and immotile cilia, and our patient also had this feature. So this diagnosis was established in the child. Now coming on to the copy number variation. So this is chromosome 11, and this is the region that was found to be deleted in the child. This is the database, that is Decipher database, that we use for studying the copy number variations. And in this we can see this in this region, these are the genes that are present. So out of these genes, the haploinsufficiency, that is when one of the allele is not present, the probability of that gene causing a disease is shown by this score. So towards 1 it is more pathogenic, and towards 0 it is likely to be a benign gene. So in this we found that there were many pathogenic genes. However, our CPAP 300 gene also lied in this region, and so this established the deletion of the gene in the second allele. And for the cause of autism, we went through all the genes, and we found that the probable cause of autism in this child was this GRIA4 gene. So basically this gene is associated with glutaminergic transmission and is involved in the assembly of the AMPA synapses. So these are the deletions which are reported till now in this region and are known to cause autism, and this was the copy number variation that overlapped with our patient's copy number variation, and this has been reported as causing autism and intellectual disability. So this established the cause of autism in this child. And a few words about GRIA4 associated intellectual disability. So till now 5 cases have been described. They have variable dysmorphic features and have mild to severe developmental delay, and autistic features were found in one of the cases. So in this child we have planned a CMA for confirmation of the CNV that was found on whole exome sequencing. She is on levepil and clonazepam for the seizures, and she is undergoing intervention for autism under Peds Neuro. And for genetic counseling, the risk of recurrence in the subsequent pregnancy would depend on whether the variant is inherited or de novo. Again, if the more like the chances are more that the deletion was a de novo variant. In case it is an inherited, then there can be again a 50% chance of recurrence in the subsequent pregnancy. So these two cases illustrate the concept of complex genetic phenotypes or multilocus inheritance that actually challenges the traditional medicine teaching. So multilocus inheritance is defined as more than one clinical diagnosis corresponding to different genetic loci in an individual, each segregating independent of each other. So the classical concept of single gene, single disorder approach, which associates all clinical features with a single genetic cause, might not be true in all the cases. So in traditional teaching, in case a phenotype is not explainable by a diagnosis, we tend to classify it as a phenotypic expansion of the diagnosis. However, the genocentric and the unbiased nature of the NGS technologies has challenged this school of thought, and it has been seen in studies that the presence of consanguinity, like in our population, and the involvement of multiple systems increases the chances of getting a multiple genetic diagnosis in an individual and family. So these were so now multiple reviews and articles are coming regarding the regarding this multilocus inheritance. So this was one of the first studies that was done in US in the network of hospitals, in which they had just retrospectively reviewed 7,000 consecutive exomes, in which there was around 2,000 patients had a molecular diagnosis. Out of them, 101 cases had dual diagnosis. So in their population, the most common mode of inheritance was autosomal dominant, and out of them 12 were CNVs. Again, this was a review from Canada, in which they had seen 802 consecutive exomes, in which 8 cases had dual diagnosis. So in this article, they had tried to explain that although next generation sequencing is important for dissecting out the phenotypes, it cannot replace deep phenotyping and meticulous phenotyping, clinical phenotyping in the patients. And this was the first study from an Indian center. So in this, they had tried to see the occurrence of multilocus inheritance in Indian population, and they had, in a family of 850 consecutive families, they found that 13 families had MGDs, and autosomal recessive mode was the most common mode of inheritance. So basically, the MGDs can have either a blended phenotype in which two different phenotypes blend and lead to the formation of a completely new phenotype, or there can be two distinct phenotypes, or there can be one phenotype with the other being predominant on it, or it can be one phenotype. The second phenotype might have a age dependent penetrance, in which case the counseling becomes even more complicated, and there might be two distinct phenotypes in different individuals in families with MGD. So what are the implications? So the risk of recurrence has to be individualized for every family. If a particular phenotypic trait is not explainable by a single diagnosis, it is important to search for an alternative explanation, and meticulous phenotyping and analysis and reanalysis of the NGS data is needed. So just a word about the evolution of the sequencing technology. So this was the landmark of in DNA sequencing, with the publication of the Sanger sequencing method, followed by the development of the second generation sequencing, that is next generation sequencing by Illumina, and by 2015 in the diagnostic field, the long read sequencing, that is Oxford Nanopore and Pacific Bioscience, have also come into play. This is the general NGS workflow. So there is extraction of the DNA, followed by library preparation and sequencing and analysis of the data, and recently in the diagnostic setting, the copy number variations are being picked up, and the efficiency of these technologies of the next generation sequencing in picking up these copy number variations is very good, to the tune of 70 to 75% as of now. So the take home messages are: a traditional approach of explaining all the clinical features in a patient by a single diagnosis might not be always true. NGS data needs to be interpreted judiciously in context of the patient's phenotype. The newer algorithms are picking up CNVs with much better accuracy. Rapid advances in developing a single unified test, probably a whole genome sequencing, for the plethora of human genomic variations is underway. Thank you.
Thank you, Somalia. So the reason for presenting these two cases were that they were very similar in the form that both were suspected to have a monogenic disorder, and along with that they have some other pathology, other clinical phenotype also. And the other clinical phenotype was because of a copy number variation. So the message here is, we are not saying that all complex cases will be solved if we do next generation sequencing. It is not the message. The message is that you have to select cases very properly. And if you suspect that there can be a combination, the dual phenotype looks like genetic, which could be chromosomal plus monogenic or two monogenic disorders, in that situation, next generation sequencing may help us. So we have to be very careful when we choose this test, deciphering the phenotype very carefully. And another very important message which I want to give here is that the lab tests like next generation sequencing, which are very high end and very useful tests as of now, phenotype is still the must. Either you do it, you have to do it before ordering the test, but you have to redo it after you get the results. That's what we call as reverse phenotyping. So deep phenotyping, reverse phenotyping is a must whatever test you do. So for clinicians like us, phenotyping remains important. So no lab test would be able to sort of just say that you have a diagnosis with lab test only. You have to go to the phenotype and evaluate the patient properly. Thank you very much. We'll be happy to answer any questions. Okay.
In this case, the reverse phenotype affection features of that patient. Now, hindsight always, that's what reverse phenotype is all about. Are there benchmarks for those flattening of the basal bridge, the basal alas? Are there benchmarks that we should compare, or is it looks abnormal?
Yeah. So this was very interesting. She came to us in the COVID period, and the reason for referral was retinitis pigmentosa and a massive splenomegaly. Truly speaking, probably, in fact, I saw this child first, and probably I did not evaluate her facial phenotype very clearly. And even if I would have seen probably mild dysmorphism, I would have passed as normal. But when we got back, after results, when we got back to the phenotype, in fact, her face quite looked like 22 Q1 1.2 deletion. There is no scoring system. As you said, this is more subjective along with other phenotypes, which she didn't have. She did not have a cardiac disease. She did not have cognitive issues, but there are multiple reports available with 22q11 1.2 deletion, only with a facial phenotype and with no other abnormality. So it's a very, very highly heterogeneous microdeletion syndrome, though commonest, one of the commonest. Yeah, that's very.
So, etiology is associated with hypertension. So, even career what one would expect to find the thymus, some levels. And without the thymus being there, it's very difficult for the B cell immunity or the humoral immunity to take over also. Therefore, how does that explain that the splenic enlargement?
So splenic enlargement, as Somalia discussed, there are many mechanisms in 22q deletion because of this immune abnormality which these children have. So one possibility was they can have malignancies which were not there. It could be because of repeated infections which was also not there. We could not document it. But then this is just hypothesized because there are very few case reports available. They say that there is immune dysregulation in these patients which can lead to manifestations like a autoimmune disorder, which can cause hepatosplenomegaly and pancytopenia.
So, was a subtype done by flow or something like that?
This was done. It will show message.
So the subtype analysis was done. It showed higher level of double negative T cells, and rest of the T cell lymphocyte subset analysis was normal, and there was deficiency of B cells.
So that is for ALPS, but we could not classify her as ALPS because for ALPS one of the criteria is that you should have a variation identified in the genes which cause ALPS. So she was not satisfying the criteria of ALPS, but it was something like ALPS-like syndrome, which has also been described in 22q11.2. Okay, thank you very much.
Good afternoon to you all. Today, after this very scintillating discussion from Pediatrics, we bring you a case from Obstetrics and Gynaecology Unit 1. I think the reason for selecting the case today has been that these cases exemplify what AIIMS is best known for, which is the availability of multidisciplinary super specialties who can work to literally deliver what cannot be done elsewhere. So we will have Dr. Shivani Mangal to present the cases, and Dr. Neha Varun is going to discuss them along with our colleagues.
Good afternoon, everyone. The topic for today's clinical combined round is circumventing. The topic for today's clinical combined round is circumventing the insurmountable block, a heartening tale of two pregnancies. So case 1 is of Mrs. X, a 25-year-old primary, married since 1.5 years, resident of Ranibagh, Delhi. She's known case of congenital complete heart block since 2 years. She was booked at AIIMS for the same at 15 weeks period of gestation and was asymptomatic and not on medications. She attended her monthly antenatal visits to look for any cardiac complications. We look for any symptoms of fatigue, tiredness, shortness of breath, syncope, palpitations, or chest pain. She was monitored for fetal growth, Liker, and Dopplers from 28 weeks onwards, 4 weekly, to look for any signs of uteroplacental insufficiency. She was diagnosed with complete heart block 2 years back during a febrile illness when her heart rate was 50 beats per minute, and a cardiology workup was done at AIIMS. In view of the same, patient was advised pacemaker, but she had refused as she was asymptomatic. There was no history of any heart blocks or sudden cardiac deaths in the family. She belonged to an upper socioeconomic status. She was graduate and physiotherapist by occupation. On her examination, she was NYHA1. There was no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. She maintained a pulse rate of 50 beats per minute, which is regular. Her blood pressure was 128/64, with a saturation of 99% on room air, maintaining a respiratory rate of 16. Her JVP was not raised. Her cardiovascular system was suggestive of no signs of heart failure. There were no murmurs, and S was to heart well. She was 16 weeks uterine size in para-abdominal examination. On her cardiology workup, her ECG was suggestive of complete heart block, narrow QRS complex with no complex ectopy. 2D echo was suggestive of no structural defects with normal ejection fraction. And 24-hour Holter monitoring was done, which is suggestive of a mean heart rate of 40 beats per minute, having a minimum heart rate of 30 beats per minute. So her cardiology review was done again in her first trimester, and patient was again advising pacemaker in view of increased maternal mortality risk, but she again refused as she was asymptomatic. All her antenatal investigations were essentially normal. Her fetal echo was done, and it was situs solitus with normal 4-chambered view and 3-vessel view seen with 1:1 AV concordance with a fetal heart rate of 140 beats per minute. She was admitted at 39 weeks for safe confinement and planning her delivery. There were no symptoms of heart failure. She was perceiving fetal movements well and maintained a normal fetal biophysical profile. Her general physical examination was normal, NYHA1. She showed no signs of heart failure, had a pulse rate of 52 beats per minute. Her per-abdominal examination suggested a uterus of term size, fetus in cephalic presentation with fetal heart rate of 150 beats per minute, and her pelvis was adequate. So there were many challenges and dilemmas associated in providing her obstetric care. So the first was that she refused for a pacemaker insertion, which increased our difficulty in monitoring, deciding her mode of delivery, and monitoring the mother during the delivery. So the essential point was deciding which mode of delivery to be provided. So there are no essential contraindications for vaginal delivery in patients of heart block. There are various advantages associated with vaginal delivery, such as decreased operative risk and early recovery, as we all know. And disadvantages were that since she did not progress for a spontaneous labor, we had a need for induction and a prolonged monitoring during the labor for worsening of any bradycardia, cardiac arrest, or symptoms of heart failure. Whereas with cesarean, we could avoid prolonged labor and a continued monitoring of the patient, but it was associated with its own disadvantages like increased morbidity of cesarean, anesthesia, and risk associated with her cardiac condition during the surgery. So finally, there were no obstetrical indications for cesarean, whereas there were also contraindications for vaginal delivery, but an elective LSCS was planned for cesarean delivery on maternal request. So a multidisciplinary team management was sought, including cardiologists, anesthetists, and neonatologists. And a pre-op preparation included arranging an external defibrillator, applying a transcutaneous pacemaker on the chest wall of the mother, having an ICU backup, availability of a cardiologist, keeping emergency drugs ready and blood arranged, and fetal heart rate monitoring was planned. Intraoperatively, we gave a slow epidural to prevent any hypertension. Continued heart rate monitoring was done, and we watched for any signs of cardiac arrest, arrhythmias, or heart failure. Post-operatively, her ECG monitoring was continued along with vital monitoring. She underwent elective cesarean under combined spinal and epidural with no intra post-op complications, and a healthy female baby was born. And she maintained a heart rate of 50 to 52 beats per minute throughout the procedure. Another patient, Mrs. K, a 27-year-old primary who was a known case of acquired complete heart block, as she was diagnosed with Epstein's anomaly in 2016, and after a tricuspid valve repair, she developed a complete AV block and a permanent pacemaker was implanted post-operatively. Patient was booked at AIIMS in her first trimester. There were no cardiac complications. Patient was absolutely asymptomatic, and her TAP, metoprolol, and ecosprin were continued. On her examination, she was NYHA1, maintaining a pulse rate of 98 beats per minute, which is regular. Her uterine size was 34 weeks, fetus in cephalic presentation with a fetal heart rate of 142. Her ECG was suggestive of normal sinus rhythm and no residual structural defects on echo. She was admitted at 36 weeks for safe confinement and induced at 37 weeks for her stage 1 fetal growth restriction, although we had to take her up for an emergency cesarean for failed induction. Perioperatively, along with our multidisciplinary team, we checked the pacemaker 1 day prior to the induction, and pacemaker settings were changed to asynchronous mode during her cesarean so that we could use monopolar cautery. She maintained a heart rate of 90 beats per minute throughout the procedure, and there were no complications, and a healthy female baby was born.
Thank you, Shivangi. Now I like to invite Dr. Neeraj from Cardiology Department for his expert comments.
So I think during the first case, actually patient refused pacemakers, so nothing for us to do, especially to provide a temporary pacemaker support in case the heart rate falls very low. For this patient, already there is a pacemaker, so we know backup is there. The only issue with pacemaker is sometimes the electrocautery used during the surgery might interfere with the pacemaker function. So it's better to keep pacemaker on a mode where it will keep on pacing and it will not be interfered by the electrical interferences that is there. So we keep it in a VO mode or asynchronous mode, so it will keep on pacing irrespective of whatever interferences are there. So that will provide a steady heart rate and there won't be any issues.
Thank you, sir. Now I like to invite Dr. Amit from Anesthesia Department.
Good afternoon, everyone. I'll be discussing the perioperative management of these two cases. So starting with the preparation, it has already been discussed, but it will be revision for some points. So high-risk consent was taken for the mother, ICU backup was arranged, transcutaneous pacing pads were attached preoperatively, transvenous pacing equipment with ultrasound machine was kept standby, close cardiac monitoring was done with the help of IABP, continuous ECG, SpO2 and multidisciplinary team approach was undertaken. So the challenges and goal for this particular patient, I'll explain. So coming to the challenges, of course, this was an obstetric patient, which is obviously different from a non-pregnant patient. So we have concerns for that and them. Then patient refusal for pacemaker insertion we have already discussed. Then there are logistic issues of intraoperative pacing. So we don't we don't use fluoro in these patients, and it has to be done ultrasound guidance if the need may be. And again, the risk of perioperative major adverse cardiac event is there. So the goals are hemodynamic stability to avoid polypharmacy as we do in all obstetric patients, optimum operating conditions and avoid complications. Coming to the plan of anesthesia, we usually have these options: general anesthesia, spinal, combined spinal and epidural. For this, usually we do all the cases of obstetrics under spinal anesthesia, and general anesthesia is avoided in general because of the obvious advantages of spinal anesthesia and avoidance of airway and multiple polypharmacy. And for this particular patient, cardiac depressants, under general anesthesia, we have to give our anesthetic agents which are cardiac depressants, and we have to use polypharmacy, which was we should not be doing that. And in spinal anesthesia, there may be sudden changes in hemodynamic parameters. There may be sudden hypotension that is not desirable, and level of blockade is sometimes unpredictable. So we chose combined spinal and epidural, where we gave lower spinal dose and gradual epidural dosing was given with the help of epidural catheter, which was inserted during the spinal anesthesia. Coming to the key points of intraoperative management. So again, we have already discussed monitoring ECG, invasive blood pressure monitoring was done, SpO2, then external defibrillator pads were attached, and isoprenaline infusion was started preoperatively before giving CSC.
So the heart rate, which was around 48 to 50, it went up to around 60 to 65. Then we placed an combined spinal epidural. We gave around 1 ml, that is 5 mg of bupivacaine heavy, and followed by a gradual epidural boluses to prevent hypotension. And intraoperatively, simultaneous IV fluid replacement was given for blood loss, and slow oxytocin infusion was given once the baby was delivered, and so the hypotension was avoided throughout, and post-operative close observation was done in the recovery. Coming to the second case, again the challenges were similar, except for the fact that this patient already had a pacemaker in situ. So we interrogated the pacemaker, then electromagnetic interference was avoided. Actually, we did not use a cautery at all in this patient, and pacemaker reprogramming was done before starting the case, and again reverted back afterwards. So monitoring and mode of anesthesia was similar, and I already discussed the electromagnetic interference was avoided because of the asynchronous mode. We already put it before starting the procedure, and post-operatively the mode was reverted back to DDDR. Thank you.
Thank you, Dr. Amit. Now going on to discussion, arrhythmias in pregnancy. The most common arrhythmia is paroxysmal supraventricular tachycardia. The incidence of heart block in general population is 0.04%, and that of bradyarrhythmias incidence in pregnancy is 1 in 20,000. Block in 70 to 90% of the cases more commonly located in the distal bundle of His. Coming to the AV blocks in pregnancy, the most common symptomatology include the syncopal attacks, exertional dyspnea, palpitations, and fatigue. And they usually have an underlying anatomic or the conduction defect. The most common presentation, they are usually asymptomatic patients with a low heart rate of less than 60 beats per minute. There are three types of the AV block. The one is the type 1 AV block, which is prolonged PR interval more than 200 milliseconds, and these patients are usually asymptomatic. Type 2 includes Mobitz type 1 and type 2. Type 3 includes complete heart block as in our patient. Symptomatic bradycardia are usually present in type 2 blocks and complete heart block patient. Diagnosis made in pregnancy on routine antenatal examinations, suspicious symptoms in second, third trimester, or in labor. There are two types of the AV block in pregnancy, acquired and congenital. Congenital is a more common variety. 30% of congenital heart blocks usually diagnosed first time during pregnancy, and congenital variety include cardiac malformations or usually the damage by the maternal antibodies. Positive family history is a very common risk factors for the congenital AV block. Fetal echo is usually suggested in these patients because they had a high risk of cardiac malformations like TOF and heart blocks in fetus. High risk of maternal and fetal mortality if the pacemaker not placed for complete heart block or in symptomatic patients. Coming to the differential diagnosis of the patient presenting with palpitations and fatigue or asymptomatic arrhythmias, majority they are physiological, then followed by premature ventricular contractions, paroxysmal supraventricular tachycardia, postural orthostatic tachycardia syndrome, AV blocks, hypotension, seizures, psychogenic, and vasovagal syncope. But we need to think about arrhythmias also, because this is the most common variety presenting. They don't usually present during pregnancy. Coming to the workup of a patient with bradyarrhythmias, starting with the history, we need to find out the baseline cardiovascular risk of the patient, complete history focusing on symptoms, family history, and medical treatment, followed by physical examination, ECG, cardiac imaging. Holter monitoring is essential for such patients, and it also detects episodic arrhythmias. Exercise testing for exertional bradycardia, CBC done to rule out infections and inflammations, and metabolic panel is also recommended, including the thyroid function test, electrolytes, and drug levels. Coming to the obstetric concerns and the risk and complications in the AV blocks, regarding the maternal, if the patient is symptomatic, the high-grade heart blocks, they present with palpitations, fatigue, dyspnea, and or syncopal attacks associated with significant mortality. During labor, there can be worsening of bradycardia, sudden cardiac arrest, angina, cardiorespiratory failure, Stokes-Adams attack, and there can be uteroplacental insufficiency. Regarding the fetal concern, there can be miscarriages, oligohydramnios, fetal or neonatal death, low birth weight, small for gestational age, and IUGR, and the premature births. So for the complete heart block during pregnancy, as we have already emphasized, we need a multidisciplinary management, including the obstetrician, cardiologist, anesthetist, and neonatologist. All symptomatic and asymptomatic patient with a wide QRS complex, 2:1 block and 3:1 block, they require pacemaker insertion. Few asymptomatic patients with congenital heart block, they may not require pacemaker if they have a narrow QRS complex. Regarding our first case, the patient had a significant congestion blockade. Her mean heart rate is 40 beats per minute. Underlying congenital heart block manifesting de novo during pregnancy, and it is likely due to hyperdynamic circulation of pregnancy. The echo was normal of the patient. It's ruled out any hypertrophic or heart failure conditions. Due to the significant mortality associated with high-grade AV block, a permanent pacemaker was advised to the patient. Emerging cases that present late in pregnancy or during labor should be counseled for the temporary pacer, followed by a permanent pacemaker in the postpartum period. Reassessment of symptoms should be performed prior to permanent pacer implantation in the postpartum period. But there are as such no established guidelines for this thing. Coming to the treatment options, among the temporary methods, we have the drugs and the temporary pacemakers, which include transvenous and the transcutaneous pacemakers. And the permanent methods include the permanent pacemaker, which should ideally be implanted pre-pregnancy, first or second trimester, or in the postpartum period. Coming to the trouble with the pacemakers during pregnancy, the ionizing radiation during fluoroscopy, they may have an adverse effect such as the fetal defect or the miscarriages. We can use certain protective measures by, for example, we can use the lead shields. Alternative methods can be used like transesophageal guided pacemaker implantation, and women with pacemaker, they usually able to endure labor stress well. But as such, pacemaker is not an indication for cesarean section. Coming to the pacemaker with energy sources, monopolar, if we are using a monopolar cautery, then we need to change the mode of the pacemaker to asynchronous mode. But if we have a bipolar cautery, then we can use it with the synchronous mode also. If the mode cannot be changed to asynchronous and we are using a monopolar energy, then we can put a magnet on the pacemaker and avoid cautery 25 to 30 centimeters near the pacemaker. Coming to the literature review, these are the cases which were published recently, and they all include the pregnant patients. They underwent cesarean because of some obstetrical indication, and there were no major complications found, neither with the mother nor with the fetus. This is regarding some studies. In 2022, there was a retrospective analysis of 74 women with a complete AV block was done. There were 33 patients with third-degree heart block, and only one patient did not receive pacing. Rest 6 received pre-pregnancy and 26 received during pregnancy. More cesarean sections were seen in the higher degree blocks, and they concluded that type 2 second-degree AV block and third-degree AV block, they required permanent pacing and vigilant monitoring, but no statistical significant complications were seen in mother or the fetus. Then this one longitudinal prospective study in 2015, they include 21 women and 28 pregnancies. The most common symptom which was seen in 29% of the women was a syncopal attack. 76% of the women, they delivered with the pacemaker, and among them 36% they had a temporary pacemaker. And they conclude that cesarean section should be reserved only for the obstetrical indications, and they all have a favorable pregnancy outcomes. So finally, to summarize, obstetrician must have a high index of clinical suspicion for underlying cardiac defects. There should be a prompt referral to a cardiologist. We should consider pacemakers in pre-pregnancy period. Temporary pacing can be done during pregnancy and during delivery if required, and they have an excellent outcomes. Consider alternative approaches for implantation of pacemaker in a pregnant patient. We can use lead shield for the fetus. Alteration of the fluoroscopy to minimize exposure to the fetus. Echocardiographic guidance or transesophageal routes can be used. Pregnancy, labor, and delivery of a pregnant patient with pacemaker are well tolerated, and again need an emphasis for a multidisciplinary team management. Now, before finishing off, I like to invite Dr. Ankit from Neonatology Department.
Thank you, Dr. Neha. So both of the newborn babies which were born, to both these cases, they were born at term, and none of them had suffered from any complication during the time of the delivery. And so we did a literature review and found out that majority of the babies which are born to the mother who are having heart block, they do not suffer from any malformation or any complication. And it is seen that the risk of prematurity, which is born, which is there in these babies which are born with the mother of congenital heart block, the risk of prematurity, it varies from 11 to 14%, and the risk of the babies being IUGR, it depends from 2 to 11%, and none of the baby was found to have any major congenital heart defect or any other congenital malformation. So, thank you.
Thank you, Dr. Ankit. Any questions? Yes, sir.
Thank you. The main role was the heart because I think we should manage these patients because of your health, sir.
Just like to say a few words. Like, this congenital complete heart block is quite a frightening thing, even for cardiologists. When you see a patient who has a heart rate of 52 or so, and you see clearly there is a heart block, P waves are there, but QRS complexes are coming intermittent. So everyone feels immediately that the patient needs a pacemaker. However, many patients, many of these patients, they are asymptomatic, and like this, both these patients, first especially, the patient was quite asymptomatic, and she has congenital, most likely congenital complete heart block, although it is not proven, but she has most likely had congenital complete heart block. That is, those who have acquired heart block, they go into bradyarrhythmia much more, and they need pacemakers much more. So for the congenital complete heart block, there are certain risk factors. Only then the pacemaker is given. Otherwise, even neonates or congenital in infancy only you find they have complete heart block. To put a pacemaker in a very small baby is very difficult. And especially when the baby is thriving and doing all right. And you see, same for school-going children, they are quite all right. So if the patient has any history of syncope, or if the patient has a wide QRS escape rhythm, then mostly they have got narrow QRS like in this patient. If the patient has prolonged QT interval, which may predispose them to ventricular tachyarrhythmias. So if the patient has complex ventricular ectopics, a lot of ventricular ectopics are also coming because of bradyarrhythmias, then these become indications of a pacemaker. And also, if the mean daytime heart rate is less than 50, like we saw mean heart rate, but generally we check on the Holter, that mean daytime heart rate should be adequate. Because during sleep the rate can come down, but if mean daytime heart rate is less than 50, then it becomes a indication for pacemaker. So otherwise the patients are asymptomatic, and they then the pregnancy as a delivery is not a problem for them. Similarly, a patient who has symptomatic earlier and has got a pacemaker, and pacemaker is established and settled and it's working all right, then that is also not much of a problem, because these pacemaker technology is quite advanced now and they are very benign. They are just not interfering with any systemic functions. So the cautery at the time of cautery, because these pacemakers, they sense the cardiac rhythm also. If the own cardiac rhythm is coming, then they don't pace. So they are sensing the electrical signal all the time. And when one applies cautery, they think that it's some cardiac signal. They suppress pacing when actually the heart is not beating. So this can be create a problem. So therefore, asynchronous mode is done so that even when the cautery is there, like the signal is there, but pacemaker will keep pacing on its own rate, fixed rate. So that is it. The major problem is when a pregnant patient needs a pacemaker to be inserted, because that is mostly done with fluoroscopy, and you don't want to expose the fetus to radiation. So then it's a little problem, and therefore these patients who have got congenital complete heart block, they should be counseled that before getting pregnant they should have full evaluation, and if the pacemaker is indicated, it should be put at that time. These are some of the points. Otherwise, the case was very well managed and very well presented. Yes, thank you.
Thank you very much, sir. And while doing this patient, I think the patient was prone that we couldn't use shortly. And there was also some issue of the technician. Technician would go home after 4 o'clock. So we put the patient in normal labor, and then patient had regressed in the night. So there was, so those were issues. we thought we said we have to save. We request to say to very direct at least 24 hours of call, like SSC person. I don't know the medical things. Those are problem, but I think it sense to you because of why you spend and you know the standards that you see. But we would say. We have more of body insights probably are admitted with us than even in like you would